Good evening all, greetings from ISCCM. We welcome you all to our most awaited monthly ISCCM webinar. This month we are going to discuss an interesting topic on critical care nephrology, which are practically needed, practically challenging day in and day out. In order to discuss here we are having our experts, Dr. Kanwalpreet Sodhiji from Ludhiana as a mentor and Dr. Pragnan Rotheji as a moderator. It's over to you, sir.
Thank you, Dr. Arif, for the nice introduction. I welcome all of you to Critical Care Nephrology, our monthly webinar. As we know, acute kidney injury occurs in 20 to 50% patients admitted in the ICU, and of which 20% require renal replacement therapy. And unfortunately, there is no robust criteria to initiate renal replacement therapy in AKI. So it is more subjective than objective. So today in this webinar, we are going to touch up very salient and practice-oriented points around this topic, which haunt us every day in and day out. To start with, I would like to give the podium to Dr. Kanwalpreet Sodhi. He's the mentor of, she has been the mentor of this webinar and she has spearheaded the whole thing. Kanwalpreet madam, over to you. She is Director and Head Critical Care at Deep Hospital, Ludhiana. Kanwalpreet madam, over to you.
Thank you, Dr. Pragyan and Dr. Arif for the introduction. And it's a pleasure to be here. Good evening, friends. So at the outset, I would like to congratulate the President-elect of ISCCM, Dr. Srinivas Samavedam, for conceptualizing these thematic webinars, which have actually become a regular monthly affair on the ISCCM platform. Sir, many congratulations. And these webinars actually have gained immense popularity amongst our members, and more so for the critical care students who eagerly look forward to attend this academic activity. This is what I have found, and I'm really, this is an appreciable effort. So coming to today's webinar, we all know, as Dr. Pragyan was saying, acute kidney injury is a common occurrence in the ICU population, but there are many dilemmas in day-to-day management of AKI. The major being the fluid therapy. Since AKI can be a result of the hypovolemia, which can lead on to oliguria, or it can per se be a consequence of the hypovolemia, the fluid overload, which we routinely do sometimes in our ICU patients. So optimum fluid therapy is a key component of AKI management. So once we were conceptualizing this critical care nephrology webinar, so we thought in this webinar, we wished to touch just the practical aspects, such practical aspects for managing the AKI. And the primary being approach to the oliguria patients, how to have a balanced fluid approach in managing AKI, as I was already emphasizing that there can be a hypo or a hypovolemia. So managing this fluid management and the intricacies of renal replacement therapy, which we as intensive care physicians, we face in our day-to-day clinical practice. And out here, I think I'm sure with the vast experience of all the speakers and the distinguished panelists we have, including the nephrologists who have of national repute. So we'll all enrich our knowledge on critical care nephrology, and I wish you all the best for this webinar. Dr. Pragyan.
Thank you. Thank you, Dr. Kanwalpreet, for wonderful. And as ma'am said, we are going to touch the basic bedside practical approach. That is what the concept of Dr. Srinivas Samavedam, our president-elect. So it will be in the form of, there will be two talk by two eminent speakers, followed by a panel discussion. So first of all, as I said, it's really totally bedside approach. So whenever you are seeing a renal failure patient, the hunting problem is oliguria. The first talk is how to approach oliguria in ICU. And to present it amongst us, we have with us a very brilliant intensivist, Dr. Sunita Varghese. She's a consultant intensivist at Bharati Hospital and Research Center, Pune. How to approach oliguria in ICU. Madam, over to you. Kindly share the screen. Share your slides.
So good evening and thanks for the kind words. And also thanks to ISCCM for giving this opportunity to me. So next 15 minutes, I'll try to touch upon a topic which is thought of as a very common and alarming, so-called alarming sign in the ICU. And before starting, I'll just go through the significance of this topic. So the first thing is, what do we know about oliguria in the ICU? So we know that urine output is the most obvious and accessible. Actually, it is one of the very first biomarkers of AKI. Even in the 100 to 200 BC, when the gallon was there, that time also it was introduced as a biomarker. We all know that it is one of the criteria for the diagnosis and staging of AKI as per the KDIGO definition. If you look at the incidence, 50% of ICU patients experience an episode of oliguria during their ICU stay. Can I remove this, the side, this box that is coming?
Hold it with your mouse and pull it rightwards, madam.
Oh,
Just do
thank
that.
you.
That's the only
Yeah.
way.
So 50% of the ICU patients experience an episode of oliguria during their ICU stay. And approximately 30% of these patients have fulfilled the criteria for oliguric AKI. What it means is this entity is common. And irrespective of the serum creatinine rise, stage 2 and 3 of AKI, as per the urine output criteria, are associated with bad outcomes. As also, the duration of oliguria and the need for RRT are associated with worse outcomes. So the second important point is that oliguria in ICU in our critical ill patients is equivalent to maybe a bad news. So when we talk of oliguria, we should know what is the definition. The literature has got many definitions for oliguria. We all know that the consensus definition as per the KDIGO summary is urine output less than 0.5 ml per kg per hour for more than or equal to 6 hours. The question is the threshold too high? This has especially come with studies in surgical patients where a cutoff of less than 0.3 ml per kg per hour was independently associated with post-operative AKI, and the odds ratios is high. So this is a Japanese study, Mizota et al. What it means is there is an importance of clinical context when interpreting oliguria in the ICU. We have to, that part is very important. The next is, what are the pitfalls when we look at the urine output as a marker of perfusion? The accurate measurement of urine output is integral to the definition of AKI. A lack of sensitivity and specificity with regard to the cause and prognosis of AKI. So taking urine output as a criteria for understanding that the perfusion, taking it as a perfusion marker, lacks sensitivity and specificity. We should remember that a measured reduction in GFR does not always equate to oliguria. And the time frame is very strict, so it needs reconciliation. Another issue is the body weight documentation. So whether to use the actual body weight, because in obese patients, it may be an overestimation. So especially in this entity, it's always better to take the ideal body weight. To understand the causes, because it is based on the etiology that we'll be treating the oliguria, we have to understand that there are three pathophysiological determinants of urine output: glomerular filtration, tubular reabsorption, especially in the DCT, and patency of tubular lumen and post-renal urinary tract. The most important is the tubular reabsorption. So this is mediated by the ADH, the sympathetic nervous system, and the RAS. So now when we compare or put this into our schematics, we understand what are the basic causes of oliguria. So this is the reduced GFR due to hypoperfusion or secondary tissue damage. So it may be a pre-renal AKI or a renal. At the tubular reabsorption level, we can again have a pre-renal AKI or a volume responsive AKI. But there is an entity which is the physiological or no AKI, which is very important to understand this, because this is the functional AKI we should recognize, and we should be able not to overtreat these patients. And the last is the post-renal AKI. So based on this, we should understand that there are two physiological AKI reasons. One is basically the hypovolemia, which leads to reduced cardiac output and oliguria through these three systems. So this is, for example, a patient who is on person who is on prolonged fasting can land up in these issues, or maybe a ultra endurance event somebody is doing, they may land up with these events. And the next entity is the perioperative AKI, which is again not always to be considered as pathological AKI. So these entities are very important. In fact, when it happens due to hypovolemia, we should take it as a conservative or compensatory approach by the body to prevent it from damage. This was initially termed many years ago as a renal success also. The other is the perioperative oliguria. We'll talk about it in a few words. And the second entity is the pathological AKI, which is used due to renal hypoperfusion, sepsis, nephrotoxins, cast nephropathy. So in the pathological entity, it is not always the hemodynamic influences, but the non-hemodynamic influences also play a part. So these are the reasons why the perioperative oliguria is not to be always considered as pathological, because almost all major surgeries due to multiple reasons are under a physiological antidiuretic stage. So perhaps the urine output criteria for the current stratification system for AKI has limited impact in the operative room. Now we directly come to the diagnostic and therapeutic approach of oliguria. So whenever we are faced with an oliguric patient in the ICU, intensivists should be able to answer the four questions. Is oliguria related to renal hypoperfusion? Will the patient respond to fluids or a vasopressor? Which is the treatment which is most appropriate? And can undue treatment cause harm? So it is always to go for a protocolized approach in these patients, because as we know, excess treatment of these patients may lead to harm to the kidneys also. So we take each step one by one. So the first step, whenever there is an oliguria, is a hemodynamic stabilization. Always remember, before going for these 4 steps, always rule out a mechanical obstruction. In the ICU, we almost should find out whether the Foley's catheter is blocked or not. Otherwise, unnecessarily, we'll be doing all the investigations and at the end finding out that the Foley's is blocked. And always, if an obstruction is doubtful, do an ultrasound or a CT KUB to find out the reason. So as I said, step 1 is hemodynamic assessment and stabilization. For this, we need to rule out hypovolemia as a cause. The MAP has to be targeted, and continuously the urine output monitoring is to be done. Now, when I'm saying this is to the category of patients who are hemodynamically stable. If the patient is hemodynamically unstable, they go into the routine resuscitation phase. So this is about the post-resuscitation phase, and plus the hemodynamically stable patients. So in this entity, we have 2 treatment prongs. One is IV fluids or vasopressors or none of them. So which are the patients who require fluids or vasopressors or neither? It's always a challenge. We should always understand that oliguria is the second most frequent trigger of fluid challenge in the ICU, first being hypovolemia. And when we give fluids, we have always understood, and there have been validated parameters to understand whether the circulation is fluid responsive or not. So we monitor the cardiac output and see. The question when it comes to the kidney is fluid responsiveness of the circulation always, does it mean that the kidney is also responsive? What do you mean by kidney responsive? Means the cause of oliguria is hypoperfusion, which is reversible and is due to increased tubular reabsorption. So is there any way to assess renal responsiveness? Not much. There have been in the textbooks role of urinary biochemical indices like urinary sodium and fractional excretion of sodium, but they have not stood the test of time. Yeah, fractional excretion of sodium may differentiate pre-renal from renal if no CKD and not on diuretics, but it has got so many fallacies. So then what to do if this is the situation? So assumption of reversibility of kidney hypoperfusion means we have to have good clinical judgment when we give fluids to these patients. There are 3 entities. One is where you know that the response is going to be there and it doesn't require any understanding. The patient is in dehydrated state. There is low cardiac output. The patient is in shock. And the third entity is when the response is unlikely. For example, the creat clearance is not deranged, shock is not there, biomarker levels are high, septic or toxic AKI, because here the reasons are not just hemodynamics. There are so many non-hemodynamic influences also that contribute to the this feature. And if established AKI, there is actually no need for fluids. So what is it that requires clinical judgment? The other clinical scenarios. So here, we need to take a proper history of the patient. We need to know the fluid balance, duration of oliguria, whether the patient is in positive or negative. And we should also know that which parameters are unlikely to be helpful. So this is about fluids. I won't be going into detail because we have the next lecture on fluids in AKI. So second is when to give a vasopressor challenge. We all know that for the proper kidney functioning, perfusion pressure is important. And the renal blood flow and the GFR are usually auto-regulated over a wide range of blood pressure starting from 70 to 80 to 170. So in this range, the renal perfusion pressure is maintained. So when should we intervene? When the MAP is less than 65 mmHg or less than 80 if chronic hypertension. And vasopressors are often indicated in vasodilatory hypotension. Now, whether increasing the MAP further will be of use is not clear. We should also remember that the urine output is not auto-regulated, unlike the renal blood flow and GFR. So sometimes it is worth taking a chance and putting the patient on vasopressor and see if a little bit of BP increase would lead to increased urine output, not through the GFR, but other mechanisms. So response to vasopressors are unlikely if the hypotension is due to poor LV function or the MAP is more than 65 or more than 80 in chronic hypertension. And in established AKI also, there is no role of vasopressors without any reason. What is the choice of vasopressor? It is always norepinephrine, but if there is any reason like arrhythmias for which we cannot use norepinephrine, you can always use vasopressin. Again, when not to give fluids or vasopressors, when it's an isolated oliguria, there are no signs of vasoplegia, hypovolemia, low cardiac output, and it is not, we are not able to explain a systemic hemodynamic reason for it. So administration of additional fluids is not indicated, because fluids are a double-edged sword. It can cause venous congestion and indirectly it can further lead to deterioration of the kidney functions. In patients with sepsis-associated AKI and after the initial fluid resuscitation, further fluid boluses are not warranted, or if at all required, it has to be in the form of challenges. Step 2 is, so we know that this oliguria has not responded to the fluids or vasopressors, or it is not needed. We have to assess the response to diuretics or utilize biomarkers to predict which patients will progress to a higher stage of AKI or severity of illness. So this, through the biomarkers, we have very limited data. I won't be going into details, a very few studies which practically we cannot apply at the bedside. The next is response to diuretics. We all know that we use diuretics on a day-to-day basis in the ICU for patients if we find them oliguric, but that is not the correct way. We have to do a proper test and understand if the tubules are responding or not. We all know diuretics act at different levels. And for the kidney, it is usually the loop diuretics we use for the furosemide, or by which the test we use is the furosemide stress test to understand if the patient has got, to predict whether the patient is going to progress or require RRT, and accordingly our therapeutic management can change. So diuretics in oliguria, we should understand that 95% is bound to albumin, so they do not undergo glomerular filtration. They are secreted at the level of the proximal convoluted tubule, and then they reach the thickened ascending loop, and here they inhibit the NKCC2 receptor. Why I'm talking about this is, suppose the diuretics are working, indirectly, it means that the diuretics have to reach the tubules, and that means the tubular integrity is established. That's the reason why this test works. So this is the hypothesis behind the furosemide test, and it is feasible and well tolerated. It is robust, appears consistent, and it is a functional test and rather than a damage marker. And the response is measured easily solely by the urine output, which may indicate the severity of the tubular injury. And it precedes the rise in serum creatinine, so it can channelize our treatment the way we do it. So how do we do it? Patient has to be adequately resuscitated, persistent oliguria, and doubtful about the response to fluid vasopressor or inotrope challenge. This is the category of patients we do this test. A bolus of 1 mg per kg if furosemide naive, and 1.5 mg per kg bolus if on furosemide in last 7 days. The response we seek is more than 200 ml urine in the 2 hours following this. Then it is FST responsive. Indirectly, it may be a pre-renal. And what you need to do is, if the patient is not fluid overloaded, we have to replace the whatever urine output is there with fluids and continue the hemodynamic optimization. If it is less than 200, it is non-responsive. It's a renal AKI. Further fluids may not benefit, and it is a predictor of progressive AKI or RRT. Caveats are that patient should be euvolemic, and whatever urine output is there, we have to replace it. It has always to be conducted in the appropriate setting. Next is the AKI workup. If this doesn't work, we find that this patient is going to proceed to the next stage or progression is imminent. We need to do extensive workup, which includes all the blood work, the urine dipstick, cultures have to be sent, microscopy, electrolytes, ultrasound, as I've already mentioned, and proper AKI treatment as per this workup is required. Based on the site of problem or the causes, we can advise the test. For example, if it is due to reduced GFR, we have to understand the hemodynamics, the fluid responsiveness, fluid balance. Look at the urine sediment to understand what is the etiology, biochemistry, and biomarker. In few patients, the blood may have to be sent for advanced testing like for immunology or the TTS, HUS workup or the eosinophil count for the interstitial nephritis or maybe a rhabdomyolysis. So in this way, we have supposed to do the testing. The urinary sediment, the most important ones are the ATN muddy ground cast and tubular epithelial cast. Then we have the shredded looking RBC fragments and the red blood cell casts which indicate glomerular disease. So these are the important ones, and the eosinophils, which is difficult to pick up in the urine because it mimics the pus cells. But if it is picked up, then it is suggestive of acute interstitial nephritis. The last is management and treatment of volume overload. So whenever the volume overload is there, we have to look for monitor for the signs of volume overload. And if the patient is diuretic, then we have to give diuretics. Patient has to be put on a fluid restrictive regimen at the outset itself. And if the diuretics are unable to control the fluid balance, then RRT should be considered in these patients. So to end my talk, I would say oliguria is common in ICU patients, but we have to understand which patients have a benign nature or a transient oliguria. It is not always an alarming sign or always should not be, it should not be a trigger for interventions at the level of hemodynamics because it may end up in damaging the patient more. It is important to recognize the pathological oliguria in a stepwise approach. Always remember that ICU oliguria is not like non-critically ill patients most of the time. It involves complex mechanisms and is associated with worse outcomes. So in view of the absence of reliable bedside measurements of renal blood flow and GFR, identifying the cause of oliguria in clinical practice and thereby change our management according to the findings is purely based on clinical context. So history taking and routine lab investigations and to be at the bedside is very important. Thank you.
Thank you, Sunita ma'am. It was a wonderful presentation about a very, very pertinent bedside topic that we discussed day in and day out. And I think if I'll ask delegates, if you have any question, kindly put up in the question box or chat box. It will be answered by the ma'am at the end. So keeping the tempo up, next speaker is Dr. Ketan Kargirwar. Dr. Ketan is a senior consultant critical care medicine at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. And he's going to answer that $1 million question of fluid management in AKI. It's a very tough topic, we face that day in and day out, how to give fluid, what fluid to give in an AKI patient. Dr. Ketan, over to you. Ketan, kindly unmute yourself. Yeah.
Yeah, thank you, everyone. Thank you, Dr. I thank you everyone for here joining on this session. And Dr. Sunita has given us a brief overview and a basic steps what every intensive care physician is practicing and should be practicing at this moment. And what my job here is to go one step ahead, and where to stop and where to start is what I have to decide. And I would like to thanks all the organizers and for Dr. Srinivas also for giving us an opportunity on this platform. So basically, fluids, why it is important for fluids in AKI pertaining we use fluid for various purposes in intensive care unit. AKI is a very common during critical illness of a patient in the ICU, and hypovolemia is accepted as a major risk factor for the development of AKI, which is the first pre-monitoring sign to develop an AKI. And we traditionally try to manage this condition by administration of fluid with the fear that the hypovolemia will remain untreated. But having said that, a propagation of AKI can lead to a increase in worst outcome or increase in the morbidity and mortality, and hence the cost of ICU. Now, where do we use these fluids basically? We use fluid for resuscitation. We use fluids for oliguria. We use fluid to replace the fluid losses. We sometimes use fluid to maintain the osmolarity, and we use fluids while doing for any parenteral nutrition. So these are my 5 main important areas where we use fluids. And time and again, there has been strong evidence that volume overload is actually harmful, and it is associated with various respiratory complications and infection and increased length of stay and mechanical ventilation. And mortality with this situation with a fluid overload and AKI is close to 50%. And patients who are going on a renal replacement therapy with this problem, the mortality goes further high. Now, why should I be worried about fluids and fluid administrations? So fluid accumulation syndrome is something we all need to remember and keep in the mind whenever we make a prescription for fluid. Remember, fluid is a drug. It is not a vehicle. It is just a drug, another drug, which you are adding every day and night to the patient's total body water. So it is fluid accumulation syndrome is characterized by imbalance between fluid intake output and leading to fluid overload and associated complications. I'm sure this is the good pictorial graph which shows how a physiological changes or a complications happen in various systems. This is from International Fluid Society. So we can have this classical image where every single organ of your body gets affected when you are going through a fluid accumulation syndrome. So my worry is fluid accumulation syndrome is what I should prevent in the ICU. Now, before I go there, why do I need fluid and when do I need fluid? As Madam has previously described, oliguria, an approach to organ. When you fail, we have to use diuretics. But not only to replace the volume status in your body, but also our focus is to prevent AKI. You either need to replace the fluid or maintain the renal perfusion pressures. And when you need to have two problems, one is hypovolume and the second is a perfusion pressures problem, the perfusion pressures problem also plays a major role in developing an AKI. And low perfusion pressure is associated with worsening AKI, is well proven. Now, when do you have a low perfusion pressure? So either there is a blood loss in a fluid compartment, or there is a decreased vascular resistance or increased vascular resistance. There is a circulatory block which can produce an obstructive shock, or there can be related to the cardiogenic shock, which can lead to a decrease in the cardiac contractility. So these are the reasons why a renal perfusion pressures can go down and you might develop a AKI. Now, what do we do now? Another physiological concept we need to remember is after after diagnosing either it is oliguria or it is a renal perfusion pressures, the fluid administration to achieve an increased kidney perfusion, fluid loading must result in increased mean systemic filling pressure, leading to increased preload and ultimately an increased cardiac output. Now, to understand this, a bit of Frank Sterling curve, which you can see on the x-axis, there is right atrial pressure, and the y-axis, there is a cardiac output or a preload. As you see, till the mean systemic filling pressures is maintained, the cardiac output and venous return is maintained. But after certain time, if you see increase in the right atrial pressure does not correspond to increase in the cardiac output, and this is the time where a vasoconstrictors or you have to institute into the your fluid management and reduce your fluid administrations, where you can transition from a hypovolumic state to a hypervolumic state. So this is the area where we have to be worried, where till the mean systemic filling pressures are adequate and giving us a preload which increase the cardiac output, you're fine. But the moment you cross the line, it can be harmful, it can be dangerous. So remember, if you are giving a fluid and if your blood pressure is improving, that does not mean necessarily you are doing a right step. You also need to know when to stop, and this can be understood very well by a mean systemic filling pressure concept. So higher cardiac output should not become your goal on itself, and a normal circulation is always a preload sensitive, as well as when the fluids are administered up to the point of no fluid responsiveness. So this can result in a harmful fluid overload. So these three things we need to remember, that every hypovolemia does not mean you have to give fluids and fluids and fluids. Achieving a goal of cardiac output does not mean that you are in the right direction. And third is we need to know when are we in a state of no fluid responsiveness. So this is one of the important strategies to decide fluids in AKI. Now, how do I'm really in my bedside practice, I decide about management strategies in an AKI. So I follow 4 Ds of fluid therapy. One is the choice of fluid, whether it is balanced salt solution, colloids, and their tonicity, or the second is duration. Second, whether to duration of this fluid and de-escalate them after my optimization. The dose, preferred way of doing the fluid management is always a small volume aliquots or a small volume carrier fluids. You can request your staff, nursing staff, to dilute the antibiotics in small volumes rather than 100 ml or 50 ml. And de-escalation, stopping your fluids at whenever it is not required, or using a bolus fluid administration. So these are certain strategies I would like to use when we are treating fluid management in AKI. Now, in general, we always have a debate what are the different areas where you use fluids. So we use fluid in resuscitation, we use routine maintenance, and we use replacement. But 50% of our fluid balance, if you see cumulative fluid balance, it goes in a maintenance fluid. Only 10 to 15% of total fluid balance has gone in a resuscitation fluid. So which is the most dangerous fluid? Is a maintenance fluid, where you have to use your strategies to minimize the maintenance fluid de-resuscitation strategies. Now coming to the which fluid, there has been various trials about, every trial has unique, but some of the new recent trials, SALT and SMART, has given us clear-cut confusion that balanced crystalloid has significantly reduced, has been better than the other fluids, and it has shown to reduce the death, new RRT, or persistent renal dysfunction. So I would always go with the balanced salt solution when we are choosing a fluid strategy in the AKI. Fluid administration strategy, now this can be a protocolized, what we learned from reverse, what we learned from various trials where early goal-directed therapy used to be followed in the last 2 decades, which was challenged later on. And recently we are practicing a personalized treatment plan. So both the protocols are there to treat this AKI to treat the fluid management in AKI. There is another strategy which is called conservative versus liberal fluid. But if you go through the research, still the the question is still unanswered about which strategy has best clinical outcome. So the take home here is basically you need to customize your own way of fluid administration. You need to remember those four principles of fluid management, 4 Ds of fluid management in AKI. And the next important point I want to emphasize here is what is the way out. So whenever you are strategizing a fluid management, have the resuscitation goals and use multimodal approach while you are deciding about fluid prescription in a critically ill patients. In these patients, especially when they are AKI, the perfusion pressures and venous assessment of venous congestion has been a new concept which is right now being practiced to identify early AKI and prevent the AKI. Now, how do we in general do what Madam has already described? I will not go into the first step when you have a patient who has impending AKI or have AKI in the ICU and you have to decide your fluid strategy. So you have to go by the standard SOP of history, physical examination, and use your invasive and invasive monitors to decide about the fluid strategy. When you decide, the step 2 after this is whether your patient is fluid responsive or fluid tolerance. Now, fluid tolerance is something is very important to decide whether you should go for more fluids or not. And how do I get that answer? So basically, when you say fluid responsive, there is large amount of literature regarding the evaluation of hypovolemia by means of dynamic predictors of fluid responsiveness. So you use dynamic predictors of fluid responsiveness to actually get the right answer. But at the same time, you also need to assess by using POCUS whether your patient is fluid tolerant or not. I'll take a simple case. For example, you have a patient who has clinical suspicious of hypovolemic AKI. You identify a possible cause, whether it is intrinsic, renal, or pre-renal, or obstructive, or whatever suspect. You identify the cardiac output of the patient by using echocardiographic or POCUS. If it is high, consider alternative hemodynamic intervention. But if it is low, then first look whether your patient is fluid tolerant or not tolerant. Like either you have a ascites or a pancreatitis patient who have high intra-abdominal pressure, or you have a ARDS patient who has lung ultrasound, or you have a VEXUS, which helps in identifying venous congestions due to cardiac failures. So you stratify your patient into fluid tolerance or not tolerance. If it is tolerant, you check for fluid responsiveness. If he's fluid responsive, then only you give fluid. If he's fluid not responsive, then wait, and the risk of fluid administration is more in that case. If your patient is not fluid and tolerant, the risk of causing damage is very high over the benefit. So this is a simple way where you would approach. You need to know when to stop while doing a fluid therapy in a patients with AKI. In sepsis, I would just like to highlight, there's been robust data right now that conservative fluid management or de-resuscitation of a patient with sepsis or ARDS has shown that conservative fluid strategy has increased ventilator-free days, decreased length of stay, and no effect on the mortality. Now, once you have spoke about the initial resuscitation under maintenance therapy, now comes to the de-resuscitation strategy, that is the ROSE protocol, where resuscitation, optimization, stabilization, evacuation, and hypoperfusion has been used. This strategy helps when to start the fluid, when to stop the fluid, when to unload the patient, if he is in a fluid overload syndrome. I would like to focus on 2 points here, that renal Doppler or a POCUS has evolved significantly in last decade. And where does it help at this moment? The renal Doppler helps to predict the development of AKI. It can predict the use of RRT should be initiated. It helps in diagnostic and therapeutic use in venous congestion and decongestion, and it also has helped in a multi-organ perfusion assessment in the shock. So, for example, if you want to do multi-organ assessment score of a venous congestion, a VEXUS score, which has used in certain subsets of patients, especially cardiac surgery patient, where they have used a combination of hepatic IVC diameter, hepatic vein Doppler assessment, hepatic portal vein, and renal vein Doppler, which has this score provides a higher specificity than an individual component for prediction of subsequent development of AKI. Now, what does it contain? So if you can see, if you have a focus, if you have an ultrasound machine and think that your patient, whether your IVC is not reliable, what else I can do? The first thing is you do a step one is do an IVC diameter, check an IVC diameter. If more than 2 centimeter, then only you focus, proceed towards step 2, which is hepatic vein Doppler. Normally, the hepatic vein flow is a pulsatile flow where you have a systole and a diastolic flow. Reversibility of those flow can indicate there is a probable a venous congestion. Then you check for a portal vein Doppler, which is a less non-pulsatile flow, and a renal vein Doppler, which is also a non-pulsatile flow. So though there would be a reversibility or a pulsatility index of both portal vein and renal Doppler to be identified, which helps in grading this Wex's score. So if you have a patient who was initially showing, if you see this case, this scenario where I have done IVC, hepatic vein, portal vein, and renal vein Dopplers. Initially, if you see there was no congestion, IVC was collapsing, hepatic vein is showing pulsatility, portal vein is non-pulsatile flow. But as soon as if you see the volume congestion has started or systemic congestion has started, IVC diameter has gone up. And if it is a confounding factor in it, correspondingly hepatic vein, portal vein pulsatility has changed, and where systolic and diastolic flows has changed, which is a marker of hepatic congestion and systemic congestions. So this is being validated only in cardiac surgery patient. It is not being yet validated in other subsets of patient. So I would recommend to use this with a pinch of salt, and it should be done by only trained professionals. So, but it is an interesting idea. It should be contraindicated in patients who have chronic kidney diseases. It should be avoided in those group of patients. There has been a lot of data about this Vexus score, which has popped up right now. Its application is still in a cohort form. Still, there is no RCT to prove that it is superior over other dynamic indices. Hence, to summarize, if you have following case scenarios in your ICU, whether you will give fluids or which is causing AKI, whether you will give fluids or whether you will assess for a fluid tolerance is what can be depicted from the algorithm which we have described. Suppose, for example, you have an AKI from true hypovolemia. Of course, the patient will be fluid tolerant, so you give fluids. He will be fluid responsive, yes, and there will be sustained benefit of the patient. Now, you have a patient who is sepsis with no comorbidities, even the same thing apply, but sustained fluid will not benefit or may not benefit. And various studies have shown in sepsis that maintenance fluid or de-resuscitation strategy has helped to improve the outcome. But if you have a patient who is having a pancreatitis with a B lines on the lung ultrasound, you need to understand whether the patient is fluid tolerant or fluid responsive. Pancreatic patient will always be fluid responsive initially, but whether they are fluid tolerant or not, we need to understand. And sustained fluid management may or may not help. The fourth case you generally see is patients who are in a cardiac center where pulmonary hypertension presenting with nausea, vomiting. If you do a Vexus score there, which actually is a need of hour in patients who are having heart failure or lung failures, where fluid tolerance will not be there, and possibly they may be fluid responsive, but sustained fluid management will not benefit in these group of patients. Similarly, a patient who have septic cardiomyopathy with no congestion and a negative passive leg raising test, such patients are fluid tolerant because they need a preload for forward cardiac output. They may not look fluid responsive in your assessment. So that time also the sustained fluid benefit may not be present. Hence, to summarize, the fluid therapy in AKI has 4 pillars. Mainly, you need to know type of fluid, whether it is isotonic or balanced salt solution or colloid. Remember, balanced salt solution help to reduce the risk of hyperchloremic acidosis and further kidney injury. Fluid balance, positive fluid balance at the time of AKI diagnosis and during first 48 hours are associated with worse renal outcome and increased mortality. Fluid overload, fluid accumulation syndrome are the new concepts which higher cumulative fluid balance within 72 hours of ICU admission has linked with increased mortality in renal and non-recovery. In a patients who are undergoing renal replacement, fluid overload at the time of initiation has been associated with higher risk of dependence on RRT and increased mortality. Thank you.
Thank you, Dr. Ketan. It is a very wonderful presentation, a very short, crispy, and very informative. I think our delegates would have got a lot from your talk. So, please unshare your slides. Great. So after that beautiful talk by Dr. Sunita about how to approach oliguria and just exactly followed by Dr. Ketan, how to give fluid therapy in an AKI patient, we would like to take up to our panel discussion. So our patient is there, and in this patient we have approached oliguria, we have given IV fluids. After that, what to do? So we are going to have a panel discussion about dilemmas in renal support in ICU. We'll follow whatever Dr. Ketan and Dr. Sunita had said. And with me, a very elite group of panelists. First, Dr. Kamalpreet Sodhi, as I've told, she is our mentor, Director and Head Critical Care, Deep Hospital, Ludhiana. Dr. Ranajit might be joining in a little bit late, so Kamalpreet Sodhi will be actively participating in the panel discussion. And next in our panelists, Dr. Ramesh Venkatraman. He's my teacher. He's a senior consultant critical care, Apollo Hospital, Greens Road, Chennai. And Dr. Ranajit Chatterjee, head critical care at Swami Dayanand Hospital. He's pretty busy. He'll be joining a little bit late. Dr. Sudakshina Malik, one of our brilliant interviewers in our part of India. She is consultant critical care services at NH Kolkata. And Dr. Valentine Lobo, consultant nephrology, King Edward Memorial Hospital, Pune. We are really delighted to have this group of panelists, and our discussion will touch upon the basic framework of renal support in ICU. To keep the ball rolling, I'll just put up a case scenario, which will make our discussion a little bit more problem-oriented. A 58-year-old male, known type 2 DM, hypertensive, admitted with urosepsis with septic shock. On admission, patient is conscious, patient is tachycardic, pulse 117 per minute, respiratory 32 per minute, BP 70/40, saturation 99% at room air, chest bilateral basal crypts, total leukocyte count 22,000, urea 72, creatinine 1.2, urine output 60 ml per hour. This is the type of patient we receive almost every day in our ICUs. And patient was aggressively assisted with IV fluids, as Dr. Ketan was elaborating a few minutes back. Central line was secured at right IJV, noradrenaline started. ABG was showing some amount of metabolic acidosis, lactate was 4, and blood and urine cultures were done, antibiotic was started. But unfortunately, on day 2, patient deteriorated. He was more breathless, NIV was put on at night. When you came in the morning, you found that he's more tachypneic with respiratory rate of 34 per minute, heart rate 145 per minute, chest bilateral course patients. It's all throughout the chest. BP 90/60 on NORAD, 12 ml per hour, roughly 0.6 mics per kg per minute. Hydrocortisone started, vasopressin added, antibiotics upgraded, and last 24 hours urine output was 4200 against 1300. So we have given aggressive fluid therapy on day 1. Labs was indicating WC count of 35,600. It has increased significantly compared to yesterday 20,000. Urea 98, create 2.8. It's almost more than 2 times rose from 1.2, what was there yesterday. Echo was showing adequate LV function. Ultrasound was showing right pyelonephritis, but no sign of CKD. And ABG was showing severity of metabolic acidosis, 7.26 with bicarb 14, lactate 7. And X-ray chest was showing bilateral opacity suggestive of pulmonary edema, whole throughout all little bit of white out of pulmonary edema across both lung fields. Urine output, when you saw it after 12 o'clock, urine output was slowly dropping from 30, 20, and 10 ml per hour in spite of all the fluid boluses as we are given. As you can see, patient is really tachypneic. And I would like to go to Ramesh sir. Welcome, Ramesh sir. Can you please tell us how will you approach this patient?
So quickly to summarize, this looks like a patient who is basically in bad septic shock with clearly AKI, probably from pyelonephritis, who has gotten worse despite fluid resuscitation, and now X-ray showing signs of probable pulmonary edema. So quickly, what will I do in this patient? ABC, airway looks okay. Breathing, from what I could see on the chart, he's breathing around 34. And despite breathing 34, clearly he's got increased work of breathing. Heart rate was 145. And despite that, the PCO2 is only 32 and clearly not compensating for the degree of metabolic acidosis that is rapidly getting worse. So my first thing would be to probably intubate this patient, take away the work of breathing, and try to compensate as much as I can for the metabolic acidosis with my ventilatory setting. So that is one part. In terms of circulation, I know patient has received a lot of fluids, but I would just do a good hemodynamic assessment with whatever tools I have in the bedside, which could be an ultrasound, echo. Look for a few things. One is the patient still any signs of fluid responsiveness? If there is a cardiac output monitor where I can look at stroke volume variation or pulse pressure variation, I would probably use that too. Number two, I would probably want to know what the cardiac function is. Is some of the shock and the rapidly progressing AKI also related to poor cardiac function, which could be sepsis induced? That would be something that I would look at. And three, the X-ray showed pulmonary edema. It may not necessarily always be cardiogenic. It can be non-cardiogenic with sepsis involved. So look for like IVC size and things like that to get a good idea of about what the intravascular volume status is. So a quick assessment all over again on the hemodynamics to make sure patient is not hypovolemic and the contractility is okay. If the contractility is not okay, I may add an inotrop. You only have two vasopressors here. I may add an inotrop to improve the cardiac output. But if the contractility is good and if it's all just pure AKI related to sepsis, then we need to think about what else we need to do. One, we would intubate for the acidosis. Two, the second question we need to answer is whether I need to increase the mean arterial pressure a little bit more. Most septic patients, we try to keep the mean around 65. This patient in the history was a hypertensive. So I may try to push the mean up a little bit more as a trial, very, very briefly, with close monitoring to see if there is any way the urine output improves with that. Number three is maybe adding a soda bicarb infusion. If you go by the bicarb trial, this patient's pH is less than 7.3. This patient has significant acidemia and shock, and correcting the acidemia would probably help the shock a little bit. So I would consider, at least temporarily at this point of time, bicarb infusion if the patient is not overtly fluid overloaded, to see if I can get the pH above 7.3. Again, that's something that I have to decide on the bedside based on my assessment. The fourth and the fifth questions, fourth option would be, like you said, diuretic challenge, bolus versus infusion. With 0.6 of norepinephrine, from what I read, and vasopressin added, the patient is too shocky right now for me to try a diuretic bolus for sure. And at this point of time, with a rapidly worsening creatinine, just an infusion without a bolus is unlikely to cause any big impact. So I would be a little wary about blindly giving bolus when this patient's shock is getting worse at this point of time, or starting an infusion without a bolus. So in that case, I would probably not do a diuretic challenge. FST generally has been thought of as an option to see the course of AKI. This patient's creatinine on admission was 1.2. It went up to 2.8. So we don't know the baseline creatinine. So this patient, if it's already been 3 times the baseline, is already in stage 3 AKI. Most of the FST studies have been done in stage 1 early AKI. In patients who are probably euvolemic and not in shock. This patient doesn't fit the entire criteria, so I would be a little bit cautious about doing FST in this patient. So that leaves us only 2 options. Should I dialyze the patient soon enough, or maybe give some time with whatever optimization I can do? I think that's a 50-50 call. I don't know the electrolytes, sodium. I don't know the potassium. So if the patient has multiple indications, fluid overload, there is already acidosis, already a little bit of hyperkalemia, and sodium low or high, whatever. So there are other factors that may push me towards early dialysis if there are so many physiological derangements that I may want to address as early as possible. On the other hand, if it's just a little bit of oliguria, a little bit of pulmonary edema on the X-ray with no significant hypoxemia, I may just optimize the hemodynamics and may even wait and watch to see if I get a window to do FST if the shock resolves. In centers where there is urinary end-gal, I may probably send off a urinary end-gal. And if it's high, then that again tells me that the acute kidney injury is far enough that I may probably need to go to early renal replacement therapy in this patient.
Thank you, sir. So, if NORAD requirement would have been a little bit less, so you would have preferred a bolus than infusion. Like this dose is a little bit on the higher
No, I
side.
would have I just want to clarify. I would probably not start an infusion without giving a bolus. Just starting an infusion at 5 milligram an hour without a threshold dose. I mean, we just talked about the FST. You need a reasonable amount of furosemide concentration into the tubules for you to kickstart the kidney. So just starting at 5 milligrams an hour or something is never going to achieve that kind of concentration, especially in a patient who has got leaky capillaries and has got a huge volume of distribution. So my answer is yes, I would ideally prefer an infusion, but I generally start my infusion after giving a bolus followed by an infusion so that I can sustain the diuresis in a more gentle and controlled way rather than just multiple bolus doses.
Great. So bolus followed by infusion, right? Sir, is there the role of metolazone? Some studies are coming regarding metolazone as a diuretic dose.
It is a more potent diuretic than furosemide. It's used sometimes when patients are resistant to furosemide. Again, in this patient, I would worry about hemodynamic stability to give a bolus of any kind of diuretic at this point of time with this kind of 2 vasopressor dependent shock. I would be a little bit wary at the bedside.
Right, sir. You already told about soda bicarb. We all do give that. So is there any way to find out when should I stop it? How long can I give it? Is there any way, is there any evidence to guide us? When should I stop that soda bicarb infusion?
The only trial that has looked at it is the bicarb ICU trial. Their cutoff of stopping the bicarb infusion was pH of 7.3. So I would not give a bolus unless it's a life-threatening arrest kind of situation, or we are talking about life-threatening hyperkalemia. So usually I just started as an infusion, and I would titrate the infusion till my pH is 7.3 or above. My logic behind that is, one, that's what bicarb ICU trial did, and two, any acidemia with a pH above 7.3 is unlikely going to contribute to the shock that we are seeing in this patient. So I would be reasonably comfortable at that point saying the acidosis is not one of the major contributors to shock, and probably I would stop the bicarbonate when the pH is above 7.3. I just go with the bicarb ICU trial.
Great, sir. I think that's a very reasonable answer. For diuretic, we should start a bolus followed by infusion, and soda bicarb we can stop or start. 7.3 is somewhat criteria as sir told. We had already told about intubation, and RRT will be discussing further. Next, I would like to come to Dr. Sudakshina Malik. Dr. Malik, is there a role of peritoneal dialysis in this patient? If you're working in a resource limited setting, like we do not have high-end machine, RRT machine, or HD machine is on the way, we do not have at present. Dr. Malik, over to you. Is there a role of peritoneal dialysis?
Hi, Pragyan, and hi, everybody. Yes, definitely. If you're working in a resource limited setting and there is no, let's say there's no dialysis unit there. And so for any procedure, we would look at indications. So yes, the indication by now, this patient already has for renal replacement, starting renal replacement therapy. And if you don't have access to hemodialysis, you can start with peritoneal dialysis. Before we start with peritoneal dialysis, there obviously, like for every procedure, there are a few things to look into. So do we have the materials? Number one, do we have the manpower, the expertise to insert, to connect, to monitor? And do we have the resources to monitor the effectivity or the patient while on peritoneal dialysis? So these are the questions that we need to answer. So I'll take them one by one. So the interface is basically the peritoneal dialysis set is a very simple set. So it consists of a trocar and a specialized catheter. Now, in this sort of setting, we will be usually using a rigid catheter, and it has some connections, and you'll need a Y connection or a 3-way with a connection to either the fluid on one end and the effluent on the other end. I wish we had a picture for this. It would be easier to describe because probably the more younger generation probably hasn't even seen PD, acute PD. But I started off in a nephrology unit, and yes, I have, we used to do that ourselves, but it's easy. It's very, the learning curve for insertion is very low, but there are certain precautions to take. Your patient needs to have a, emptied bladder, number one. They can't have any intraperitoneal pathology going on, whether it be medical, like an infection, active peritonitis, or tuberculous peritonitis, which is common in our country, or any scarring or hernia of the abdomen. Now, once you've inserted it, like I said, you have to make the connections. And what you need to monitor is basically the intake and output on an hourly basis and on a cumulative basis. Now, there are some other things to monitor like potassium, the acidosis, and the prescription also is very simple, I should say. There's only one type of fluid, basically almost one concentration of fluid. This can be bought commercially, and I was asking a nephrologist friend of mine the other day about this. So they said that companies actually do we take the effort of reaching this commercial fluids to even far outreach places of India at least. So that's good news. So that, that prevents the necessity to make the fluid on your own, which can increase the risk of infection, introducing infections into the peritoneum. Now, besides that, you have to monitor, also you have to, besides the intake output, you have to monitor the electrolytes. That's mainly the potassium. And the prescription is that it basically depends on, if you have hyperkalemia, you give quick. So the idea is that you allow the, what should I say, the fluid to the fluid to flow into the peritoneal cavity, stay for a certain duration of time, and then you clamp, the in part and you let go. It's just a three-way system, and the effluent comes out, and this is what you monitor the output. So if you have hyperkalemia, very quick exchanges, say in time, so the passage of the fluid into the peritoneum is called the in time, and the passage out is called the out time, and there's an intermediate dwell time, which is the time for which the fluid will remain inside the peritoneal cavity. If you have hyperkalemia, you'd give very fast exchanges. So let's say 10 minutes in, 15 to 20 minutes dwell time, or even 10 to 15 minutes dwell time, and out of 10 minutes, let's say. If you have fluid overload, you'll be adding 25% or 50% dextrose, if available, to the in fluid, with a Y connection, and that's going to increase the osmolarity. So basically it acts by, it takes the help of the peritoneum being a semi-permeable membrane, and it draws from the peritoneal capillaries. It basically draws the solutes and the fluid along with it. So if you want to remove extra fluid, you need to give a higher dose of dextrose, osmolar, active particles.
Right.
And if you, and acidosis is the one that gets corrected more slowly. So a peritoneal dialysis, if started, will be continued for at least 24 hours, and it might be extended right up to 72 hours. So all this is, the learning curve is also, so long as the nurses know how to, get your equipment, do the connections, and monitor the intake output, it's kind of easy to do in a resource limited setting.
Excellent, madam. Very well said. So we have a role of peritoneal dialysis in acute care setting. That's what the take home is. Can you tell us which patient can go for peritoneal dialysis specific? Which patient profile you would like to? Like, as
so,
you have seen both.
Yes. Yes. So even in today's ICU, in the ICUs of larger cities, where you also have hemodialysis, you can use peritoneal dialysis. So the basic idea is that, this concept came out from the COVID, because previously what was happening is that this peritoneal dialysis on acute kidney injury was being used only in low middle income or low, the low middle income and the middle income countries. And there's also an initiative by the International Society of Nephrology, which is called Saving Young Lives, and it's targeted mostly to Africa, Southeast Asia, and Latin American countries. And so they use it, but it also what happened during the COVID times is that Western countries saw that they were getting their dialysis the hemodialysis unit actually was getting overwhelmed. And so there's been a resurgence of the use of acute peritoneal dialysis in Western countries also. That's one. And second is that the evidence also shows that none of them is superior to the other. So as far as efficacy is concerned, it can also be used. Now, coming to the patient profile in peritoneal dialysis. So any patient who has AKI can be given peritoneal dialysis. That's one. Secondly, I did mention the metabolic parameters like hyperkalemia with quick exchanges, hypertonic exchanges with in case of fluid overload, and prolonged PD in case of acidosis. Now, besides these, there are other, in outreach areas. You can use it in snake bite. You can use it in disaster scenarios, like in a disaster camp, let's say. You can use it, let's say there's, large trauma and rhabdomyolysis. There's lots of casualties with trauma and rhabdomyolysis. It can be used in those sort of patients also. So these are the sort of patients, in whom we can use peritoneal dialysis.
Great, ma'am. That is quite an insight for all those new generation intensivists who have not yet seen.
Yes. So it's actually very easy to learn, like I said, and it's a very useful skill to know for the intensivist.
Great. Taking further, I think we should be popularizing it in
Absolutely. I totally agree with you.
I'll come back to you, ma'am. Sure. Next is I'll go to Dr. Valentine Lobo. So in this patient, as Dr. Ramesh told a few minutes back, renal replacement therapy is the next thing we should be doing. What will you prefer in this patient? Hemodialysis, SLED, or CRRT? Valentine Lobo, sir, over to you.
Right. So I think the clear answer is, which mode would you prefer? The one which the team and looking after the patient, including everybody, is most comfortable with. Because if you go to trials and systematic reviews, there's not a single part study which is big enough, or even a meta-analysis which says that one is superior to the other. There's just one meta-analysis, 2021, by, it's a Chinese one, which said that SLED-F, that is sustained low efficiency daily diafiltration with online substitution fluid, was associated with a 40% survival benefit, which was statistically significant. However, otherwise, no study has shown that intermittent hemodialysis, SLED or CRRT is superior. And so it should be the one which the team is most comfortable with doing. As Dr. Malik just said, if you want to do peritoneal dialysis, you have to be, the material has to be available, the expertise has to be available, and that goes for any form of renal replacement therapy, I think. So I would probably, in the patient you have chosen here, you have presented here, I would probably choose SLED. The patient is on noradrenaline and vasopressin. There's ample evidence to say that patients who would not tolerate SLED also did not tolerate CRRT. That's what studies have shown. So I would choose SLED in this patient as the modality.
Excellent, sir. I think we matched with you. So this patient was put up on SLED only. Sir, in SLED, we have seen flow rates of somebody from 150, 100 to 200. How do you decide the blood flow rate? That amazed us intensivists a lot of times. How do you decide the blood flow rate with this NORAD requirement?
Okay. So first of all, there has to be, this is something that is coming from dialysis nurses and technicians, and to some extent, I'm afraid, the nephrologists, that the higher blood flow rates are associated with hypotension. Now, as somebody who has been doing dialysis for the last 29 years, this comes from the era when dialysis machines were non-volumetric, and wherein the transmembrane pressure was increased if you increase the blood flow rate. Today, all machines have volumetric controlled ultrafiltration. So as long as the ultrafiltration will not change no matter what the blood flow rate is, you dial in the ultrafiltration on your machine and it will not be affected by blood flow. So the concept that a patient who has more hypotension, more pressures should get a slower blood flow rate should be removed straight away. Blood flow rate does not produce hypotension. So also there has been a change in the prescribed blood flow rates. When SLED first came in somewhere around 1999-2000, slower blood flow rates were used around 150 to 200. Today, it is prescribed between 200 to 300. The higher the blood flow rate that the vascular access will give, the better it is, because we can do across the world, around 50% of SLEDs are done without anticoagulation. So if you can get a better blood flow rate, you are likely to get a better circuit life in SLED. less likely to lose your circuit due to coagulation. So the highest blood flow rate that your vascular access will deliver and the least number of alarms is what should be the blood flow rate. Also, as we have started using low efficiency diafiltration, we have added a convective clearance. And when we do this, the filtration fraction increases. So better the blood flow rate, lower will be the filtration fraction and more the efficacy of the procedure. So I probably prescribe today blood flow rates of between 200 to 250, which is what I can get from a temporary access.
Excellent, sir. Excellent. That is a very eye-opening statement. So how do you decide the duration, sir? 8 hours, 12 hours, or 16 hours? Some put up 6 hours also. How do you decide the sled duration?
Yeah. Okay, that's an excellent decision. The ultrafiltration rate and target should decide the duration. Now, there is a very excellent study by Raghavan Murugan and John Kellum and another one from the Mayo Clinic, which said that if you can achieve a daily net negative balance in AKI patients with fluid overload of 25 ml per kg per day, that means for a 60 kilo adult, you need a net negative balance of about 1.5 liters per day. The 1 year mortality is significantly lower in these patients than if you did not achieve this net negative balance. Now, if you want a net negative balance of say 1.5 liters and the patient is going to receive an obligatory intake with his nutrition, his antibiotics, his pressor infusions and perhaps blood products of 1.5 liters, then the prescribed ultrafiltration to achieve the net balance should be 3 liters. Remove the 1.5 liters which you're going to give and also achieve a net negative balance of 1.5. So we would be prescribing 3 liters. Now we did a randomized controls trial in SLED and it's just going up for publication. What is the best tolerated ultrafiltration rate? Because SLED, unlike CRRT, is going to be carried out for a part of the day and not the whole day, although in the rescue study, both were of similar duration. 4 ml per kg per hour is routinely well tolerated. So for a 60 kilo adult, that would be about 250 ml per hour. Now we want to target 3 liters per day, and we're going to be able to achieve a net ultrafiltration rate of 250. So 12 hours would be what I would target in this situation. So my principle of deciding would be how much ultrafiltration do I want to achieve and what is the safe rate at which I can achieve it, which is roughly about 4 ml per kg per hour. So in this patient, if I have a 60 kilo adult in whom I want to take off 1.5 liters net negative balance, who's going to get 1.5 liters of obligatory intake, making it necessary for me to take 3 liters off, I'm going to do 12 hours of SLED.
Excellent, excellent, sir. I got it. So 12 hours is good enough. So for an intensivist, what we need to be careful when we are dealing with SLED?
Right. So when dealing with SLED, there are a couple of things that we need to be careful with. We need to avoid hypotension because there are two classic studies, Silverside study and then the Mayo Clinic study by Kashani and Teranian, which showed that every hypotensive episode increased mortality and renal non-recovery. So we need to avoid hypotension when we are doing any form of RRT, SLED or CRRT. We need to, the longer our duration, and in the rescue study, as I said, the average SLED duration in the day was 15 hours and the average CRRT effective time was 16 hours. So they were nearly the same. The longer the duration of SLED that we do, we need to adjust the bicarbonate and potassium of the dialysate when we are doing it. So it's the prescription would be, if we are doing an 8-hour SLED, we can keep our bicarbonate above 30 and we can keep our potassium between 2 and 3 in the dialysate. If we are doing 12 hours or longer, we should drop our bicarbonate down to about 28 to avoid too much of post-SLED alkalosis, and we should keep our potassium at around 4 in order to avoid severe hypokalemias, which would arise in this situation. Also, because SLED is carried out for a long duration, the efficacy, it's called low efficiency, but that's referring to individual sessions. If we have done daily SLED daily for 3 to 7 days, we will need to look at our calcium, phosphorus, and magnesium because these would almost invariably be depleted. And we have learned this the hard way. When we check our phosphorus after 7 days of SLED, we find the phosphorus is 1.5, and we wonder why our patient is proving difficult to wean from the ventilator. There is muscular weakness, neuromuscular weakness because of hypophosphatemia. So we invariably need to look at phosphorus, calcium, and magnesium after about 72 hours of SLED and replace them if they are low in order to take care of the other aspects in the patient.
Thank you, sir. So, a lot to learn from this slide. So, out of hemodialysis, SLED, and CRRT, no one has proven to be better among studies. And when we are dealing with SLED, blood flow rate doesn't decrease BP, and duration doesn't matter. Whatever you require to, however and whatever way you want to remove the fluid, accordingly you can set up the duration. And intensivists need to be little bit careful about electrolytes and bicarb when we are dealing with many things to be careful about when we are dealing with SLED. Thank you, Lobo sir. I'll come back to you. As Dr. Ranajit has not yet joined, I'll ask our mentor, Dr. Kamalpreet, to take up the question. If you have only hemodialysis machine, like my hospital, we got SLED machine 2 years back only, can we do some modification in prescription so that we can do some slow dialysis in HD machine? Kamalpreet, madam, over to you.
Nice question, Dr. Pragyan. First of all, we ought to know that in all the hemodialysis machines, we can actually go in for SLED, modifying the prescription. But certainly for the students, I would like to highlight that we always talk about, when we talk about intermittent hemodialysis, we say it has to be a hemodynamically stable patient. But there are certain modifications, yes, we can do for hemodynamic tolerance to IHD. And the first and foremost is we must start the session by dialysis alone without any ultrafiltrate. And thereafter, looking at the hemodynamic response, we can adapt the ultrafiltration rate. And that too, ultrafiltration alone, actually without a diffuser solute removal. The second foremost thing we ought to do is cool the dialysate to around 35 degrees Celsius, because this highly reduces the risk of hypertension. Not only cooling the dialysate, but also limiting the bath temperature to less than 37 degrees. And more important is avoiding the warming of the patient during the dialysis. This all will reduce the risk of hypertension occurring in any hemodialysis patient. Then any vasodilator therapy, if the patient is on, we must stop. That is something which is a must. But there are certain technical aspects which we should look at. Usually, although we routinely use the biocompatible membranes, the cellulosic membranes, they are said to be more hemodynamically stable. And then when we connect the lines of the circuit, both the lines simultaneously should be connected, and after filling it with normal saline and then connecting directly to the catheter, that can also prevent sudden drop in blood pressures. So this maneuver we can use. And as Dr. Lobo was stressing upon, that limiting the blood flow rates does not actually cause the hemodynamic stability. So, but still we can go up to 200 mils per minute in a intermittent hemodialysis also, but certainly with a minimum duration of 4 hours. If we set a minimum duration of 4 hours, that also will prevent the hypotension occurring. So all these maneuvers, along with a high dialysate sodium levels. We should have a sodium level of more than around 145 millimoles to optimize the hemodynamic response. So all these things we can collectively do so as to have a hemodynamic stability in a IHD patient.
Thank you, ma'am. That was wonderful. So also don't lose heart if you do not have SLED machine. Hemodialysis machine can also be modified to do some sort of slow dialysis. That's a very nice thing to understand. Ma'am, can you highlight something about dialysis disequilibrium syndrome that is not very uncommon complications when we are doing dialysis for the first time or second time?
So actually, dialysis disequilibrium syndrome is more of a occurrence in chronic kidney disease patients rather than in our acute settings with systemic and the neurological symptoms we all talk about. So it is of less occurrence in our critically ill patients in the ICU settings. But routinely, what is recommended to prevent the dialysis disequilibrium syndrome, we can limit the first dialysis session to shorter duration with around 2 to 2.5 hours, what is recommended. And the blood flow rates of again around 200 to 250 mils per minute. And a high dialysate sodium that actually prevents the disequilibrium, which occurs because of mainly the electrolyte and the imbalance and the cerebral edema occurring. And furthermore, we might use mannitol up to 1 gram per kg as a maneuver. Mannitol can be given, and or in the specific group of patients, we actually might have to avoid intermittent hemodialysis and might have to shift to CRRT, especially for traumatic brain injury patients or patients with acute liver failure. So those population in such patients, the occurrence of dialysis disequilibrium is higher, and we can use these modalities, or we'll have to shift to the CRRT.
Thank you. Thank you so much. Thank you. So day 3, we'll again go back to your patient. Patient deteriorated with triple inotropic support and vasopressus. Patient is anuric, ABG has worsened, lactate has increased, plan was to do CRRT. I'll again come back to Ramesh sir. In this patient, if you are planning for CRRT, what mode? Of course, it's a very vast question. I can almost cover a day of discussion, but quickly, can you tell us what mode of CRRT would you like to do over here?
So in this patient, in any patient, if I just only want fluid removal, I'm going to do ultrafiltration. If it is solute removal, it's going to be either diffusive clearance or convective clearance. So in this patient with sepsis, I probably would like to do CVVHDF, continuous venous hemodiafiltration, which has a diffusive component and a convective component. And there is some evidence and theoretical advantages to adding convection to dialysis, especially in patients with sepsis and hypercatabolism. So I would probably go with CVVHDF in this patient.
Thank you. So can you highlight where you're going to do CVHD or CVVH specific patients? Where you're going to apply this modes, CVVH, CVHDF or CVHDF? Just briefly, sir.
So clearly, if it's only predominantly volume, for example, with CHF, you're going to do slow continuous ultrafiltration, where most of it is just ultrafiltration. We don't have to worry about solute clearance. If there is solute clearance, people either do CVVH, CVVHD or CVVHDF. I think if the patient is not hypercatabolic and you think you can just get away with the good diffusive clearance of only urea and creatinine, you're not worried about anything else, then I think CVVHD would be good enough. CVVH is only convective clearance, which I frankly have not used and not seen used quite often. And most often in an ICU setup with the hypercatabolism and inflammatory process going on, a little bit of diffusing and convective clearance with CVVHDF is what we would do. And all the studies that have looked at CRRT, mode, dose, everything have only used CVVHDF. That's one more evidence-based reason to use general CVVHDF.
So I agree. So that's a very nice comment. So most often we use
Again,
CVVHD.
can I add a practical issue here?
Yeah, sure. Okay, you can add up now, sir.
One, for those who are using the Gambro machines, either Prismax or Prismaflex, the practical reason to choose CVVHDF is, as Dr. Ramesh said, there's no difference among the modalities. But if you choose one of the others, then you can't go to CVVHDF midway through. So you choose the most complex one, CVVHDF, and if you want to convert it to CVVHD or CVVH, you just make one of the pump speeds 0. But if you start by choosing CVVH, you can't add a diffusive clearance. If you start by choosing CVVHD, you can't make it CVVH or CVVHDF midway through.
So you can de-escalate, you cannot escalate. That's what I'm suggesting. So let us better start with CVVHDF. If patient gets better, we can go back to CVVH or CVVHD. Hybrid, sir.
Yeah.
Point taken, sir. Again, I'll come back to you only, Valentine Lobo, sir. So, what is the rule of early versus late? Like Elaine study has said that early is better than late, but subsequent studies like Idle ICU, Start, Akiki, all have said that there's no difference between both. What is your take on that? Whether you should be starting CRT early or late?
So what all the studies have told us is, first of all, this early versus late, you mentioned Elaine. Now, Elaine was different from the other two because the early group of AKI, KI and Ideal ICU was the late group in LA. So early versus late, perhaps we should get rid of that concept, because what all the studies showed is that if there were complications of AKI, which were the conventional indications, hyperkalemia, pulmonary edema, metabolic acidosis not responding to bicarbonate, then this group, this is when you just had to start renal replacement therapy. Additionally, what AKI-KI2 showed was that if you waited more than 72 hours of oliguria or allowed blood urea to climb more than 240, then the 60-day mortality was significantly higher. So not waiting too long is as important as not starting too early. If one delayed, then ideal ICU told us that the delayed group had a slightly higher incidence or significantly higher incidence of hyperkalemia, though fortunately it did not translate into an adverse outcome like mortality. And if you started too early, then AKI, KI said there was a 3 times higher risk of catheter-related bloodstream infection. And in START AKI also, all the complications were higher in the early group, including the 90-day non-renal recovery was higher in the patients who had received early. So certainly starting too early doesn't offer a benefit, and it may actually have some degree of harm, especially late in the course of illness, like non-recovery and like catheter-related bloodstream infection. Also, most importantly, in AKI, KI, and in START, there were about 38 to 49% of patients in the late group who recovered without needing renal replacement therapy. So these patients would have unnecessarily been subjected to a line and an extracorporeal therapy when they did not need it. Unfortunately, when I go through all the studies, I do not find any point which will enable us to say which is that group, how to identify the group which will recover without and the group which will require treatment at a later date, because that was the group which did worst in terms of mortality. The mortality was 64% in the group which got delayed late RRT. So that group does worst of all. So on balance, if the patient has conventional indications, pulmonary edema, hyperkalemia, metabolic acidosis, encephalopathy, pericarditis, these are the group which I will start without thinking twice about it. And in the other group, I would prefer to wait, as Dr. Ramesh Venkataraman said earlier, the bicar ICU, you couple those findings with it, you can try to correct acidosis initially at least with bicarbonate infusion and wait to see if the patient stays oliguric, go on to renal replacement therapy.
I think that answers very appropriately. So not too early, not too late, somewhere in between. We'll come back to the question again, subjective versus objective decision regarding it. Thank you, sir. Thank you. I'll again go back to Dr. Malik actually. So Malik, so we have started CRRT here as mode was described by Dr. Ramesh. So what dose would you like to start with?
Yeah. So Pragyan, that's the obvious next question. So this would depend on the effluent rate. Now that's the rate of blood purification per unit time. And how do we measure it? We measure it by the difference between the net ultrafiltration and either the replacement and or the dialysate fluid. And it's expressed as milliliter per kg per hour. So this is basically what we want to target. So the effluent rate, most studies, they've compared higher and lower rates of effluent rates, and they've shown eventually that somewhere between 20 to 25 milliliter per kg per hour is what works best. And higher rates than that, and I'll just discuss higher rates and the pros and cons of, advising higher rates. But one thing needs to be kept in mind that whatever we prescribe is not necessarily what the patient gets. So there is something called a prescribed rate and there is something called a delivered rate. Now there's approximately the delivered rate we target about 80% of the prescribed rate. So if you want, so actually we're looking at delivered rate. So the number that I mentioned, 20 to 25 milliliter per kg per hour would be the net delivered rate. So we have to prescribe something that's 20% higher than that, and that would be about 25 to 30 milliliter per kg per hour. Now, why does this gap occur? Sometimes there are it's very common that the filter gets clogged and there are alarms going off and you need to change the fluid, and the patient is not there in the bed, needs to go for a procedure or something. So there are lots of time gaps. Again, there's a target number, which is about 80% of the time of prescribed CRRT that the patient needs to actually get the CRRT. So that's the target. It's just like, we have chest compression fraction of 80%. So 80% seems to be the golden number here. Now, the question is, what if we prescribe higher effluent rates? Is that good or bad? The problem with higher effluent rates, barring the evidence, is that the patient tends to lose, nutrients and your drugs, the small molecule water soluble drugs and electrolytes. So the patient also will land into a lot of problems. But there are certain conditions in which you would target higher rates, which would be hypercatabolic states like rhabdomyolysis, tumor lysis syndrome, or in toxin removal. So there's there's slightly more to it than it seems. And the other important thing to look at is the blood flow rate. Now, the blood flow rate depends on whether you're giving dialysis or filtration or diafiltration. So in dialysis, you would try to, keep the hemodialysis rate about twice your dialysis rate.
Got it. Got it.
Your dialysis flow rate, yes. And in hemofiltration, the target is the filtration fraction you need to, which is the rate of fluid removed, the ratio of the rate of fluid removed to the rate of plasma blood, to the rate of plasma flowing. And this you need to keep at less than 25%. And in hemodiafiltration, which would actually in hemofiltration come to about 150 to 250 milliliters per minute of blood flow rate. Now in hemodiafiltration, it is a bit more gentle, and the rates prescribed would be about 150 milliliter per minute. So that's more or less about the dosing.
Got it, ma'am. Got it. So I think that's a very precise way you told about the dose and what are the dilemmas surrounding the dosing actually. So I'll again come back to Dr. Kamalpreet actually. So what are the anticoagulation you use in your practice, ma'am, for CRRT?
Okay. Dr. Pragyan, actually for CRRT, anticoagulation is a must. But as Dr. Lobo was saying that not only for intermittent hemodialysis, even for SLED, we can go without any anticoagulation at all with the fluid boluses, right? But while giving those fluid boluses, we have to keep in mind the fluid balance. So the ultrafiltrate has to be increased as per the amount of fluid boluses we are giving, right? And then when we talk about the anticoagulation, we all know that systemic and the regional anticoagulation with the benefits and the problems associated, like bleeding with the systemic anticoagulation and the regional anticoagulation having some technical issues. But lately, now another technique has come up is the hybrid anticoagulation, wherein we combine the low doses of unfractionated heparin along with some platelet aggregate inhibitors. So this is another thing which has come into being, but the anticoagulation varies from unfractionated heparin with the benefits of like it's a short acting and easily reversible with protamine. So all those things have in mind, and even regional heparin has been tried, but although the incidence of bleeding has been higher, then there are the low molecular weight heparins, not much used in AKI patients, and going to regional citrate anticoagulation. And in patients who have heparin-induced thrombocytopenia, even the direct thrombin inhibitors like ergatroban and vivalidine have been used. But for regional citrate anticoagulation, I would say that if at all we have to use, we need to have a defined protocol in place. We ought to know what are the practical problems associated with regional citrate anticoagulation, because since how this acts, we all know that once we inject the citrate, it inhibits the calcium. So thereafter, the hypocalcemia is one of the major problems associated, and we have to monitor the post-filter calcium levels. More so also associated are the hypernatremia, metabolic alkalosis, acidosis, because of citrate intoxication itself. So there are many problems, and we ought to have a stringent monitoring, a protocol, fixed protocol should be there. How frequently we are going to monitor the electrolyte, how frequently we're going to monitor the ABG, what should be the target calcium levels. So all those have to be defined before we go in for the regional citrate anticoagulation. But yes, because citrate being a buffer along with an anticoagulation, it is certainly beneficial. And most of the studies have shown that it has less of bleeding complications and a much longer filter life. I think Dr. Lobo also agrees to that.
I agree fully. And I agree fully with what you said, that you must have access to an ABG with the ionic calcium, which comes within 15 minutes because it's no use trying to adjust the prescription on an ABG calcium which was done an hour ago, and if it takes that long for the report to come. So I agree with you fully.
Exactly, sir.
Exactly. Thank you. So it's sort of it's an art in itself. So managing anticoagulation CRT, we need to be more careful, as told by Lobo sir and Konpit Pen. So I'll again come back to Valentine Lobo sir. So how do you ensure antibiotic dosing? Like common antibiotic that we use in septic patients, how you ensure that my patient is getting right dose of antibiotic?
Right. So you've given me a massive topic to cover. So I'm going to just go over very few basic principles in it. And for anyone who wants to look at it more, I think the most excellent source is an article which has been published in 2021, a systematic review by Matthew Rollins and Jason Roberts in Journal of Pharmaceutical Practice and Research. It's an Australian journal which has the most excellent guidelines. In basic principles, convective clearance will increase the clearance of higher molecular weight antibiotics. So when I looked up these, the two highest molecular weight antibiotics which are cleared more by convection are colistin and teicoplanin. So these two, if you are doing a convective clearance, will be cleared more. As a rule of thumb, if you are doing a CVVH with a effluent rate of 25 ml per minute, the clearance of vancomycin is approximately 15 to 25 ml per minute. If you are doing a CVVHD at 25 to with an effluent rate of 25 to 30 ml per kg per hour, then the clearance it's approximately equal to a GFR of 25 to 30 ml per minute, and the drug most removed is sodium valproate. If you are doing CVVHDF with 25 to 30 ml per kg per hour, the clearance is higher. It's about 30 to 40 ml per minute, so one would dose accordingly. We need to increase the dose of certain drugs on CRRT, most notably daptomycin. It needs to go to a dose of 7 to 8 milligram per kilogram. Cefepime, which has to go to a dose of 1 to 2 grams 8 hourly, meropenem and piperacillin tazobactam. And therapeutic drug monitoring is mandatory for vancomycin. When it comes to SLED, it is said that the approximate clearance is about 100 ml per minute for most drugs at a blood flow of 200, a dialysate flow of 100, and a dialyzer of about 1.4 square meters. The drug which has to have its dose increased during SLED is most notably doripenem. So the maintenance dose of doripenem in a SLED or session of 8 to 12 hours has to be 750 milligram 8 hourly. Imipenem has to be dosed as if the patient had normal renal function, as compared to the dose reduction which is normally done in AKI for imipenem. Additional doses of all carbapenems should be given at the end of a SLED session, as also for the cephalosporins, especially cefepime and ceftazidime. So it's in fact for cefepime and ceftazidime, the dose has to be 12 hourly on the day when SLED is done, and it has to be 24 hourly on a day when SLED is not done. Aminoglycosides have to be dosed. Gentamicin, for instance, the dose has to be increased to 8 milligram per kilogram every 48 hours, and it is not to be given after a SLED session, but 1 to 2 hours before a SLED session to achieve a high peak concentration and then a low trough, which would be correspond to toxicity. Fluconazole doses have to be increased. All echinocandins and linezolid have to be dosed as if for normal renal function. And the drugs for which there isn't sufficient data are colistin, fosfomycin, rifampicin, and cotrimoxazole as far as SLED is concerned. One principle that is to be adhered to is loading doses should not be reduced. Loading doses should be increased. A loading dose, especially of carbapenems and cephalosporins, should be 25 to 50% higher than the normal recommended dose because of the increase in body water in patients with AKI who are fluid overloaded, and because it is essential to achieve killing at an appropriate rate with the necessary therapeutic drug concentration. And vancomycin mandates therapeutic drug level monitoring. Very fortunately for me, I get a vancomycin level within 6 hours of sending the sample.
I think that's a very nicely answered question, sir. Some loading dose have to be increased, and you have to be careful about the maintenance dose. Thank you, sir, for answering so nicely, such a vast idea. Dr. Malik, I'm coming back to you. How do you ensure that patient is getting adequate nutrition, somebody on CRRT?
It's a very interesting question, Pragyan. Whenever we're looking at nutrition, we break it down into carbohydrate, protein, lipids, vitamin, minerals, water. So here, just that in the ICU, we deal with the energy part and the protein part. So energy will be from carbohydrates and lipids. And so somebody who's on CRRT, actually critically ill in the ICU, for them, the dose of your energy, the energy, should be about, say, 30 to 35 kilocalories per kg per day. Right. And the ratio of carbohydrate to lipids should be about 2:1. For proteins, on CRRT, it should be about, there's slight difference in the different guidelines. So it's between, say, about 1.5 to 1.7 gram per kg per day in one of the guidelines, and the other one up to 2.5 grams per kg per day. So let's say it would be somewhere between 1.5 to 2.5 grams per kg per day. And if you're looking at the other, the electrolytes, so that's, yeah. So if you're looking at the electrolytes, then the losses are mainly of potassium, magnesium, and phosphate. And it is best to replace the potassium and phosphate in the fluids. It's in the dialysate fluid itself. And magnesium can also be given, but it can also be given as a slow IV infusion, which would be more common in our ICUs. The micronutrients to target would be copper, zinc, and selenium, which are the commonly lost. And the vitamins to look at would be, there's actually, recommendations for the daily doses of all these nutrients in patients on different modes of renal replacement therapy. And so there's a long list of those, and the vitamins to the important vitamins that I've lost are, thiamine, vitamin C, and there's folic acid. So these are the ones that, we regularly give our patients folic acid when they're on dialysis. And besides the fluid, obviously the fluids, as in any critically ill patient in the ICU, it's going to be what you want, your assessment of the hemodynamics and the intravascular volume status of the patient versus the total intakes and the total outputs, taking into consideration the insensible losses also, which might be increased in patients who are more severely ill. So that would be about the list if you're asking only about CRRT.
Dr. Pragyan?
Pragyan, you're unmuted.
So,
yeah, I mean, you're muted. You need to unmute. Yeah.
Fine. Thank you, ma'am. That's very nicely answered, actually. We have to be keenly observing the electrolytes, nutrition part in terms of calorie, protein, and carbohydrate as well. Ramesh sir, I'm coming back to you again. So, role of special filters in sepsis, like cytosobs, few of us use in septic patients. When, how frequently, and which patients you're targeting?
So a quick overview about the various filters. We have filter that can absorb the path. We're talking about absorption here as a mechanism of immunomodulation. So one, filters that can absorb pathogens, the Cephro, which is not widely available. Two, specific adsorbents, which absorb endotoxin, which is the polymyxin filter, and non-specific absorption filters like the cytosob, which non-specifically absorb both pro and anti-inflammatory cytokines. And then there are filters which kind of absorb both, which would be the Oxidus filter, which could be used. If you look at the evidence is strongest for the polymyxin filter. There are two major randomized controlled studies. The first is the UFAST study, which showed a mortality benefit with polymyxin filter. The caveat there is most of the patients were surgical patients and not much medical patients. A subsequent study looked at medical patients, the EUPHRATES study, which did not show any survival benefit with the polymyxin filter. However, in a subgroup of patients who had the endotoxin level, which was in the medium range, which is between 0.6 to 0.9, there seems to be a mortality benefit. So if your endotoxin level was too low or too high, obviously it did not work. The subsequent filter, the cytosob, which is a non-specific cytokine adsorption filter has had no major randomized controlled trials that have actually showed substantial mortality benefits. A lot of the small studies have shown only physiological benefit in terms of hemodynamic stability and PaO to FiO2 ratio and things like that. However, recent evidence consistently, there has been 2 or 3 good papers that have shown harm with cytosorb with possible potential for worsening mortality. So that's something that is important to understand at this point of time. Oxaris is a new filter which can actually do 3 things. 1, it can do CRRT. 2, it can absorb endotoxin. 3, it can absorb the cytokines. And the data is emerging. There is some data to say it does have impact on outcome, but we don't have any robust data at this point of time. So if I had to choose a filter, I would look at the endotoxin. If I have availability to endotoxin level, then I would look at endotoxin levels. If it is in the range of 0.6 to 0.9, then I would probably pick a polymyxin filter. If I do not have endotoxin assay available within a reasonable period of time, I probably would stay away from cytosorb at this point of time because of the risk of worsening mortality that is emerging. In this particular patient that you have presented, if you think we're going to do CRRT, I may actually just go ahead and use the Oxaris filter because there is no data that says it's harmful yet. There is possible benefit. And anyway, this patient is going to need CRRT. I might as well use that filter to do CRRT so that I can get whatever additional advantage I can get with immunomodulation. When would I do it? Number 1, I think we need to understand that basic sepsis care has to be done. It is not a replacement for the basic septic care. Adequate fluid resuscitation, appropriate antibiotics with good dosing. Try to do source control as much as possible. Despite all this, if the shock is worsening, probably I would say in the first 12 to 24 hours, I think it will take about 12 hours to do the basics right. And then at that point of time, I think I would consider one of the immunomodulatory devices if the patient's shock is rapidly worsening and I need some kind of a salvage therapy. Most of these filters that have been studied, each filter has a different kind of frequency and duration, but most of these filters, the cytosorb, the polymyxin filter would be, I think, at least 2 treatments. Cytosorb similarly can go up to five treatments if necessary. Oxaris is just a CRRT filter. I think you just start and keep going, and then you can, when the CRRT clogs, you can decide whether you want to use the next Oxaris filter. Most often when we have used probably for 2 days. The duration, depending on various studies, can be anywhere from 4 to 12 hours with any one of these adsorption filters except the Oxaris. And then what we have done in our ICU is 12 hours gap and then another 12 hours. If we see a response good, there's absolutely no response, then no point in continuing further. I think which patients, obviously, we said patients who have adequately been otherwise treated for sepsis and the shock is rapidly progressing. And we need some kind of a salvage therapy to probably buy time and get them out of where we need to. We have used it in some patients where we just need to buy time to do source control. Patient is too sick, we can't move them for a CT, we can't move them to the OR to do whatever we need to do. So just buying time for another 12, 24 hours, reducing their level of shock, and then trying to get a good CT or move them to the OR. Once or twice, we have used it to kind of bridge to buy time. So those are all the times where I would use. The take-home messages are the evidence is strongest for polymyxin filter. So if you have an ability to do endotoxin assay, do that and then take a call. At this point of time, I would recommend staying away from cytosorb. And Oxaris is something that if you think patient needs CRRT like this patient, it's something that you could probably use at this point of time to get whatever extra cushion you can get in terms of immunomodulation along with CRRT.
Very nicely said, sir. Thank you. And the next question to you only, Ramesh, sir. What if this patient is planned for ECMO along with CRRT? How to integrate for the best results? Although it's a very vast question, you can answer it briefly, sir, if possible.
Okay, so just a quick, I'll just tell you what we do. If you look at CRRT in ECMO, there are so many ways it can be done. I'll just tell the main principle is whenever the blood is coming out of the CRRT filter, you want to make sure before it goes into the patient that there are no air embolism that are happening. So what we do in our ICU is that the inflow to the circuit comes after the oxygenator, the outflow from the CRRT machine back into the patient is given proximal to the membrane. Either it is between the pump and the membrane or proximal to the pump. In that case, hopefully we can catch the air bubble and not worry about any air embolism. So see, the ECMO flows are usually around 3 to 4 liters per minute on an average for most people in our country. And the CRRT flow is going to be 150 ml per minute. So there's going to be a very small amount of recirculation that's going to happen within the ECMO circuit because of the CRRT. But the 150 ml in a 3 to 4 liter per minute flow is probably mostly clinically insignificant, and usually it doesn't need any extra equipment because you already have too many equipments and pumps in the machine that we just connected to the ECMO circuit as I described. It probably be the easiest way to do without adding more equipment and resources.
Thank you, sir. Very nicely said. It's a tough job, but with good hands, it can give very good results. I think we have skipped 1 or 2 questions because we have pretty nicely exceeded our time limit. But it was a very wonderful discussion. I would like to give away to Kalpit ma'am as our mentor to give us the last word.
Last word, I would pass on to Dr. Lobo first.
Okay,
Dr.
fine.
Lobo,
So
sir.
it's up to you how you're going to judge
Yeah.
that.
It's
Yeah.
because, see, we have such a experienced nephrologist with us, and we would like to have his opinion about this, sir.
Okay, thank you, ma'am. I think the only thing points that came to me is, as I said, one of the things that I stressed at the beginning, and I think somebody asked me in one of the questions in the chat box also, why not CRRT, why SLED? So as I said, I would choose what is I'm most comfortable. Today in my unit, fortunately, we are equally comfortable with all the modalities. I have been doing PD for almost 30 years. But we have moved away from the rigid catheters today to soft catheters, which we insert at the bedside, the soft cupped catheters. And we often send cardiorenal syndrome patients home with the catheter from the ICU to continue peritoneal dialysis as a maintenance. So it is in cardiorenal syndromes that peritoneal dialysis seems to work best. It doesn't work too well in hypercatabolic and septic patients because it just cannot achieve the clearances which SLED or hemodialysis or CRRT do, but it can still be life-saving. Dr. Malik pointed out very beautifully that snake bite, disasters, rhabdomyolysis, crush injuries, it is life-saving. One of the problems is that when you are using vasopressin and noradrenaline, then the splanchnic circulation constriction, vasoconstriction is high, which reduces the efficacy of peritoneal dialysis to some extent because the peritoneal blood flow goes down. One of the practical things that we do is to add nitroglycerin or nitroprusside or diltiazem in the peritoneal fluid, which produces some local vasodilatation and improves both the fluid removal as well as the biochemical efficacy of PD. We've been doing it for a long time, and we've shown that both the efficacies improve by about 25%. An additional problem with peritoneal dialysis is that in India, at least, all the fluids that are available are lactate or acetate based. There is no bicarbonate based fluid. So that means that the same contraindication to citrate, that when the lactate is more than 6, don't use regional citrate, means that we cannot use peritoneal dialysis either when the lactate is very high. And of course, if the patient has had an abdominal surgery, we cannot use it. Something that is emerging, of course, it requires ultra pure water, but we are using it now, is to use online SLED with online replacement fluid. Our water then has to have a bacterial count of less than 1 organism per 1,000 liters and an endotoxin level of less than 0.03. So we do this with the help of a basic reverse osmosis system and then a portable reverse osmosis system connected between the water outlet to our dialysis machine. So it enables us to do a convective plus diffusive clearance with very high efficacy at the bedside. And that is probably the way to go in the future at a much lower cost. The daily cost of this is about 7,000 rupees. CRRT, comparable CRRT costs us about 30,000 rupees a day. So this is one of perhaps the treatments that we should be looking at, but with the caveat that if our water is not of the quality, then we would be making our patients worse with a load of endotoxin. So continuous estimation, continuous quality control is required. And finally, what the ADQI 17 or 18, I can't remember which, said, we need to move from doing renal replacement therapy in the ICU to precision renal replacement therapy. So that document on precision renal replacement therapy is one which I liked a lot, especially the part about fluid balance, estimating net ultrafiltration and fluid balance every 1 hour as part of precision RRT rather than once a day. Thank you.
Right, sir. Dr. Lobo, there was one question that can we use peritoneal dialysis for the toxin removal like paraquat?
No, paraquat cannot be. Paraquat is not removed even by hemodialysis or CRRT. It requires an adsorptive filter. So currently the only one which we have been using for paraquat is the HA230 filter, because the old Adsorba Gambros charcoal filter is no longer available. So the only thing which works for paraquat very early is the HA230, and it's now coming with a kit for testing the paraquat level in the urine. And you can show with the help of that blue color, the dithionate reagent which they are supplying along with the HA230, whether the paraquat level has been reduced or not. And if it rebounds, then we do a second HA230 filter.
To end up, Dr. Ramesh, a last word from you, sir.
No, I think we have covered everything. So thank you for the opportunity. I think it's a vast topic. I think Pragyan and you have done a fantastic job putting together a good series of talks and a series of questions that have addressed all the key issues related to renal replacement therapy. So congratulate both of you and thank you for the opportunity.
Thank you, sir. Dr. Sudakshina?
So, I really agree with one of the first things that Dr. Lobo said is that, do what your unit is comfortable with. And obviously, we skipped that question because Dr. Ranjit wasn't there. So I was very interested actually whether it is the intensivist call or whether it is the nephrologist
There was
call.
short of time, so we had
Yes.
to skip some questions.
Yes, I agree.
We have already
But that
exceeded
would be, really interesting for all of us to debate that out.
We can
But
have a debate in one of the ICCM
with
forums.
time, yes, with time and many years of working together, I think it does become seamless. There's not much difference, I would say, in the approach towards our prescriptions that we, the nephrologist, as an intensivist, I can say that once they're comfortable with you, they will allow you even to prescribe and change the prescription if in the middle of the night something goes wrong on a sled, and they don't want to be disturbed, obviously. So we are the ones who will take the call. And yes, so we do learn to take decisions on behalf of the nephrologist. And I think that is also another level of, working together.
Actually, I
And
also
yes,
think that
personal,
we have
yeah.
to work hand in hand with the nephrologist.
Yes, absolutely.
We cannot work all alone.
We cannot work
The
on our own
nephrologist
and
in the
they go
ICU,
on their own.
obviously, he needs a intensivist around, and an intensivist going in for either CRRT or SLED. We all need the nephrologist's opinion,
Yes,
right?
yes,
So we should work
yes.
hand in hand. And
Yes,
as we are
absolutely.
doing, and we always have Dr. Lobo or one of the senior
Absolutely.
nephrologists around.
And there are
in
many,
this
it's good that, many nephrologists are really interested in critical care.
Right.
So I've been lucky to know one, when I was in my training, Dr. Argham Majumdar, I think sir has heard. So he used to, regularly be on our rounds with Dr. Todi every day. So that was a huge learning experience for me personally.
So because of shortage of time, we had many questions which we had tried to answer individually, or even Dr. Lobo has answered few of them. But because of short of time, we have to close the session. And I would like to thank each one of you, both the speakers, Dr. Sunita and Dr. Ketan. You were wonderful and made the things so simple, working at the bedside, managing the oliguria and fluid management, which are certainly a very difficult topic in AKI. And all the panelists, thank you so much for being here. And I would like to congratulate Dr. Pragyan, who has actually moderated the session so well. Thank you, Dr. Pragyan, and thank you, Dr. Arif Pasha and Dr. Gunjan Chanchalani for convening these webinars so well. Thank you so much. Good night, everybody.
Thank you.
And
Good night. Good night, everybody.
Happy Diwali to all of you.
Bye. Happy Diwali.